Good morning once more. I'm going to deal with a simpler topic about the challenges and opportunities for transitioning to the clinical use of long-acting ART. Those are my disclosures. In this talk, I will try and address what the fuss is all about, the implementation evidence that is there, the practical aspects of using long-acting ART, and the considerations that we should be pondering on for our low and middle income countries. So every time we talk about long-acting injectables, we seem to have questions more than answers. The science is solid. We know the drugs work. We know that people will virologically suppress. We know that in clinical trials, participants preferred injections to oral pills, and we know for a fact that where ART, long-acting ART has been rolled out, people have preferred long-acting ART. So why are we constantly thinking through things? Are we hoping that long-acting ART is going to solve adherence issues? Or do we think that the long-acting formulations are good for our difficult populations, which is our adolescents, our mobile workforce, and the patients with a chaotic life balance? Do we think, as clinicians, as researchers, that patients are going to love the idea? Patients have often said that they have struggles remembering their pills. So we think, as clinicians and as service providers, that they don't have to remember these tablets. One of my patients said every time she carries her handbag to a nightclub and carries the bottle of her ARVs, the noise they make tells the rest of the people that she has pills in her bag. Are we thinking we are going to tackle the stigma issues by giving long-acting injectables? At the same time, healthcare providers think that it is going to increase the burden for them and that the cost might not be attainable. The one thing we know for a fact is that we do need long-acting agents. We might not need the long-acting agents we think we do, but we need long-acting agents because psychologically, people who are on chronic medication do suffer from pill fatigue. They do have anxiety and depression around taking pills every day. Taking pills reminds them of their HIV status, and there could be a preference among the people living with HIV for other modes of administration. Socially, long-acting injectables do provide privacy and are convenient for people. Biologically, we know that there are people who struggle to take pills because of one condition or another. There are people with cognitive difficulties. They cannot remember to take their pills every day, and long-acting formulations work for those people. Now we're looking at briefly at some of the implementation projects that were done, and we will look firstly as customized. Now I struggle to see those slides there, so I'll briefly look at my slides over here. Customize looked at the perceived external factors that affected CAB-LA implementation. If you look to your right, you will notice that they did a survey at baseline, at month 4, and at month 12. And they did the survey on both the healthcare providers and the patients. And you can obviously see that there's a big difference there. The proportion of service providers who thought that patients would have a problem keeping their appointments started at 81%. The proportion had decreased to 38 and was 39 at month 12. People who thought that patients would have transportation issues, it was 77%, and it decreased to 43% by month 12. The awareness of missed visits decreased from 73 to 22%. I will not list everything, but you can see that over time, service healthcare providers changed their perceptions once they had started giving these long-acting injectables. If you look at the graph on your right, those are the perceived barriers to implementation amongst both the participants and healthcare workers. And it is so strange that these are like inversely proportionate. Where the patients thought there could be a challenge, the healthcare providers did not think there was a challenge. So healthcare providers, though they were 23 in number, thought that the biggest challenge would be the injection soreness. They thought that patient transportation, rescheduling of visits would be a challenge. The patients on the other side did not think that transportation or missed visits was a challenge, but they were concerned about injection pain. If you look at the Carlos study as well, they interviewed the patients about the challenges with daily HIV medication prior to switching them to LA-ART. 32% never had problems, then 68% had problems with daily ART. Amongst the issues raised by those who had problems with daily ART, the first one was that the daily HIV medication routine was not convenient for them. I'm emphasizing that. 34% felt that they had to hide their pills, so there was a stigma issue there. Some of the participants felt that taking the daily oral pills reminded them of their HIV status and that they would forget to take their pills. The last one I want us to look at is Carousel. So Carousel looked at the visit times for the LA injection visits, right? So they looked at month 1, month 2, and month 6. And as you see, month 1, the visits were longer and they kept decreasing over time. By month 6, the patients were spending less time at the clinic for their injections. So what does this tell us? It tells us that the patients had concerns and the patients had genuine concerns, but healthcare providers seemed to have a different perception of the concerns that the patients had. Now, if we look at the practical aspects or the challenges that we must think of when we are implementing or transitioning in the clinical setting to long-acting injectables, we must look firstly at our healthcare delivery systems. Are we ready for long-acting injectables? Do we have the infrastructure? Do we have everything we need for long-acting injectables, particularly in this continent? We must also look at patient factors, which will differ across the provinces, across the regions, and across the countries. Healthcare provider factors. There's also a different perception of the value and the risk. So healthcare providers want to think about the time that they will spend, the visits to the clinic. They want to think about the cost only. But the patients are also thinking about what is the value of me not taking oral pills. It cannot be translated to money, but it increases my quality of life. But we don't have a value or a rand value or a cent value to the quality of life. We must also be very clear that, especially clinicians and researchers, we have issues with change. We want what we know and we want to stick with it. There are also comorbidities and concomitant medications that we should look at as well, as the frequency of monitoring. As the low and middle income countries, the first thing we must look at is the ability to comply with the scheduling requirements. Our cities and our villages are built in such a way that sometimes healthcare facilities are not easily accessible for our patients. How are we going to navigate that? We have a highly migrant workforce. I'm South African, and I know that in South Africa we've got Zambians, Malawians, Zimbabweans, a lot of people from the Southern African region. How are we going to navigate the fact that they are highly mobile, they have to go home for their holidays, and those holidays might be more than 2 months? Patients usually have an erratic lifestyle. Rilpivirine, as has been mentioned, needs cold chain storage because it must be stored between 2 and 8 degrees. Are we able to have cold chain requirements? We have the huge issue with hepatitis B co-infection. And how are we going to handle pregnancies in people who are receiving these long-acting injectables? Of concern is the drug-drug interactions, specifically rifampicin, because we still have a lot of people that have TB and are taking rifampicin. Clinical considerations as well for the clinicians in the room. We do know that there are factors that are associated with increased risk for virological failure. And those are: 1, a BMI above 30, 2, HIV subtype A6 and A1, which is not a problem in my region, 3, archived rilpivirine resistance associated mutations. Almost all of our patients have been on NNRTIs. We don't do resistance testing when we switch patients who are stable on their regimens. How are we going to approach these clinical considerations? 2, the fact that the current guidelines recommend switching patients who are stable and suppressed on their online regimen, on their baseline regimen, is a bit of a concern, because there is a thinking that long-acting injectables should actually be given to those that are struggling with adherence. There's also the issue of the pharmacokinetic tail that's been mentioned numerous times in this conference, and the special populations that need to be looked at. But I don't want us to only look at the challenges. I want us to talk about the opportunities that we already have for this transition. The first one is that we have very good immunization and family planning services. Our clinicians and our nurses are well trained on giving injections. So we do not have the challenge of having to train people to give injections. Unfortunately, in clinical trials, CAB and rilpivirine LA are given as 2 separate injections, 1 on each buttock, and they are given preferably on the ventrogluteal site, which is on the side, and not the site that we are used to. It's a bit tricky to start giving injections on a part of the body you were never trained in, but once you get into it, it gets easier. 2, the COVID vaccine programs actually were very good for us because we now are able to maintain cold chain. We were able to get the vaccines into the most rural areas despite the fact that we call ourselves low and middle income countries. 3, most of the countries have got very well-trained community health workers that are assisting with the daily oral therapy for TB, that are assisting in following up cases from the clinics, and we should take advantage of those people. We should be able to train them to further assist the rollout of long-acting injectables or any other long-acting formulation for our populations. 4, most of the countries are making use of mobile clinics where patients don't have to come to the treatment site, but rather a clinic goes to where the patients are. We should be able to take advantage of such services as well for the rollout or for transitioning into long-acting injectables. The last one is about communication. Almost every country has got connectivity. Even if it is not internet connectivity, but almost everyone has a mobile phone. Now, the mobile phones don't have to be the ones that are advanced and you can download apps in, but we should be able to use bulk SMS services to send reminders to patients that your appointment is due next week. Please inform us if you're not able to come so that we can talk about an oral bridging course or whatever else. Bulk SMSs work remarkably well. The other communication we have is that we have community advisory boards and community groups that are very active in our communities. We should engage those and try and get them to understand what these formulations are, because they are the ones who are going to be able to reach people. We are sometimes, as clinicians, as scientists, viewed with suspicion. But if the message is spread by people in their language who speak the language and are able to explain things in a way that people understand, we should not have problems with transitioning. So in conclusion, the rollout of long-acting injectables is imminent in some of our regions. As you saw in the map that was shared, some of the countries have actually approved long-acting injectable therapy. Some are pending approval. So we are almost there. And so healthcare providers need to start adapting their organizations, their clinics, so that we're able to deliver long-acting injectables to patients who might need them. Long-acting therapy is feasible even during a pandemic, I must emphasize. The other thing I must state categorically is that this is not for all patients. Not all patients will transition to long-acting injectables. We need more evidence, obviously, for important populations, but even for our normal patients, there are those who will not find long-acting injectables suitable for them. But the last point is that people living with HIV do desire to switch, and that desire outweighs all our concerns, all our anxieties as healthcare providers. The least we could do would be to train ourselves, to go out there and practice where there is a practice session, attend all the training so that we become familiar with what is expected when we transition to long-acting injectable therapy. I thank you.